Dr. Daver, what are we learning about patients with untreated AML who are ineligible for intensive chemotherapy? Will intensive chemotherapy be a thing of the past in the near future?
There has been a major shift over the last 4 or 5 years towards using lower intensity combinations such as the azacitidine venetoclax in patients who are definitely above 75 and not fit for intensive induction. I don't think anybody debates it in that population, but even in patients 60 to 75 years of age who are borderline, and maybe we could give intensive induction chemotherapy and get patients through it with supportive care, antifungals, antibiotics, close monitoring, but we're seeing similar remission rates with azacitidine venetoclax with much less toxicity, much less ICU stay, and less mortality. And especially if the goal is to get a number of these patients to allogeneic stem cell transplant, which it is, then we feel that the lower intensity, better tolerated, smoother remission, getting patients in a good condition to allogeneic transplant may be the way to go. Now, of course, to really make this standard of care, we have to look at this in a randomized fashion to make sure that what we believe is actually what the data is going to confirm. So there is an ongoing randomized study looking at the azacitidine venetoclax lower intensity therapy versus the traditional intensive chemotherapy called 3+7 in patients 18 to 65 years of age. And that study will, I think, give us a lot of information and data as to whether we can start replacing intensive chemotherapy for a large proportion or majority of AML patients, even those who are younger. Today, I don't think that intensive chemotherapy is a thing of the past. I think for patients who are below 60 or even those who are 60 to 65, we are routinely doing intensive induction chemotherapy. One has to realize that the 5-year survival for many molecular and cytogenetic subsets are close to 50, 60% with intensive induction chemotherapy. Whereas with HMA venetoclax in the older unfit, we're looking at 3 to 5 year survival rates of about 30%. So we have still not seen data in younger patients with HMA venetoclax to be convinced that this will replace intensive chemotherapy altogether. I think the signal suggests that there is a potential for it to do so, especially with the use of allogeneic stem cell transplant, which we're using quite frequently, and or maintenance, but that has not yet been established. So I would still say we do use intensive chemo in those who are young and fit. So my activation tip for this is that there has been a lot of progress in the lower intensity therapies over the last 6 to 7 years. A decade ago, we would not even be asking whether there's anything that can replace intensive chemo. Today, we do have data with HMA venetoclax that suggests that it may be as good as intensive chemo, looking at the response rates, MRD negativity, and especially with 3 drug combinations where we're adding targeted therapies to HMA venetoclax, those response rates and depth of responses are looking as good, if not better than intensive chemo. So there are now randomized studies ongoing that are going to be looking at intensive chemotherapy versus HMA venetoclax. And if those show equivalence or superiority for HMA venetoclax, I think in the next 5, 6 years, there will be a huge shift towards less use of intensive chemotherapy in the frontline setting, but we're not there yet.